Our topic will be remplissage when Bankert repair is not enough. This is the mechanism through which the dislocation occurs. As we all know, the glenohumeral instability, where the humeral head goes to the anteroinferior aspect to engage the anterior glenoid labrum, creating the classical Bankert soft tissue and creating the bony Bankert and the Hill-Sachs lesion, and these both are the bipolar osseous lesions occurring in glenohumeral instability. The instability-related bone loss is a strong predictor for the recurrence and is a major risk factor for failure of the arthroscopic Bankert repair. So what is the Hill-Sachs lesion? It is an impaction fracture of the posterior superior aspect of the humeral head due to a traumatic anterior glenohumeral dislocation, first described by Flower, but it had been named after Hill and Sachs, who are radiologists who had been the first to describe the mechanism by which it occurs. It occurs in 67% in the first time dislocation and reaches up to 80% in the recurrent shoulder instability. It can be classified according to the size by row classification. It can be classified according to the depth of penetration by Calandra et al. And it can be classified according to the percentage of the involvement of the humeral head by Flatto and Werner. After the introduction of the glenoid tract by Di Giacomo et al., we had been able to classify the Hill-Sachs lesion into an on-track lesion, which is a Hill-Sachs remaining on the glenoid tract and not engaging the anterior glenoid labrum, and consequently no risk of dislocation, and an off-track, which is an engaging lesion in which the Hill-Sachs lesion is out of the glenoid tract and with a risk of engagement and dislocation. Our main aim is to transform the off-track Hill-Sachs lesion into an on-track Hill-Sachs lesion, which is mandatory to regain the glenohumeral stability. This is the calculation through which we can define whether the Hill-Sachs lesion is an on-track or an off-track. Here is the measurement of the glenoid tract, which is normally an 83% minus the bone loss from the normal glenoid. And this is the Hill-Sachs interval, which is the length of the Hill-Sachs lesion with the associated bone bridge. If the Hill-Sachs lesion interval is more than the glenoid tract, then this will be an off-track and engaging, leading to a recurrent instability. However, if the Hill-Sachs lesion is less than the glenoid tract, then the Hill-Sachs lesion is on track and not engaged. Itoy et al. Had proposed an algorithm for the management of bipolar lesions in glenohumeral instability. If the glenoid bone loss is less than 25% with a Hill-Sachs lesion which is on track, then he proposed the soft tissue procedure, an arthroscopic classical Bankert repair. However, if with a bone loss less than 25% with an off-track lesion, then we will go for an arthroscopic Bankert lesion with a remplissage, and lethargy could be added as an option in throwing athletes and in contact athletes. If the glenoid bone loss is more than 25% with a Hill-Sachs lesion which is on track, the glenoid bone need to be reconstituted and we will go for a lethargy. However, if the Hill-Sachs lesion is off track, the lethargy is our main option, but if the lethargy alone couldn't restore the Hill-Sachs lesion to be on track, then we will add a humeral-sided procedure like the remplissage or the bone grafting for the humeral head. So our treatment option for the Hill-Sachs lesion is the remplissage, the rotational osteotomy, the osteoarticular allograft transfer, the disimpaction, a partial prosthetic resurfacing, and finally the lethargy or any other glenoid procedure grafting to increase the length of the glenoid arc to keep the Hill-Sachs lesion on track. The remplissage as a word means twofold. However, the concept, it is an arthroscopic infraspinatus stenodesis with a posterior capsulodesis, filling the Hill-Sachs lesion bed and rendering it as an extra-articular. Originally described by Connolly, arthroscopic modification described by Wolf and Pollack, the main aim is to keep the humeral head, the Hill-Sachs lesion no longer engaging the anterior inferior glenoid labrum, and the posterior capsulodesis act as a brake, decreasing the anterior translation of the humeral head and consequently reducing the recurrent dislocation. So it is mainly indicated for a recurrent anterior shoulder instability with a Hill-Sachs lesion, which is off track with a glenoid bone loss less than 25%. In addition, in cases with a glenoid bone loss more than 25%, when the letter J alone is not sufficient to make the lesion on track back again. And also, it is indicated for moderate to large Hill-Sachs lesion, especially when it is more than 20% of the humeral head involvement and with a medial lesion. Let's go for this clinical case scenario. This is a patient, 23 years old, professional basketball player with history of recurrent shoulder dislocation. As we can see from his radiology and measuring the Hill-Sachs interval and measuring the glenoid track, it had been found that the Hill-Sachs interval is more than the glenoid track, and consequently, the arthroscopic Bankert repair alone couldn't be the perfect solution, and the glenoid bone loss is less than 25%. This is the dry scope for the patient, and here after starting the irrigation with saline, the lesion is clearly apparent at the anteroinferior glenoid labrum, which is the classical Bankert, and here is the humeral head Hill-Sachs lesion engaging the anterior glenoid labrum intraoperatively. Here we go for debridement and creating a bleeding bone bed for the Hill-Sachs lesion, together with the introduction of the anchor into the Hill-Sachs lesion, and finally retrieving sutures through the infraspinatus tendon with the two limbs. Then we will shift anteriorly to go for the classical Bankert repair. Tying our knots. And this is our final repair. The evidence based for the arthroscopic remplissage together with the Bankert repair is supporting it as a safe procedure, reliable in patient with a glenoid bone loss less than 25% with a Hill-Sachs lesion which is off track. So my take-home message: for a successful remplissage, you should mobilize the Bankert lesion before the remplissage, evaluate the location and size of the Hill-Sachs lesion, prepare a bleeding bled for the remplissage, place 1 or 2 anchors depending upon the size of the Hill-Sachs lesion, and suture should pass laterally through the infraspinatus and not through the medial capsular structures. To conclude, the arthroscopic remplissage with the Bankert repair provide an effective, safe, and reliable procedure for the treatment of glenohumeral instability cases with large and medial Hill-Sachs lesion. Thank you.